Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. My email is sreeklpm@gmail.com. I am also the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with the series of Neuro Imaging concepts. So today we are going to talk about subarachnoid hemorrhage. Neuro Imaging concepts, part 30, hemorrhagic stroke, part 5, subarachnoid hemorrhage. Subarachnoid hemorrhage. This is the fourth most frequent cerebrovascular disorder. This is the fourth most frequent cerebrovascular disorder. Subarachnoid hemorrhage is due to rupture of an aneurysm is the most treacherous. Subarachnoid hemorrhage due to rupture of an aneurysm is the most treacherous. So what is aneurysm? Aneurysm is the dilatation of the artery, and generally this aneurysm formation occurs when there is branching of the arteries, like the bifurcation of the middle cerebral arteries, or at the anterior communicating artery, or at the posterior communicating artery. It occurs at the branching of the arteries because of the high pressure. There will be dilatation of the vessels and then weakening of the vessels leading to the rupture. So subarachnoid hemorrhage due to rupture of an aneurysm is the most treacherous. So when the normal vessel is there, the thickness is good, but when it starts dilating, the vessel wall becomes weakened, and then as it starts further dilating, there will be rupture causing hemorrhage. And since the circle of Willis is in the subarachnoid space, and when the vessel wall dilates and ruptures, since the vessels are in the subarachnoid space, the bleed is also seen in the subarachnoid area. So that's why we have subarachnoid hemorrhage confined to the subarachnoid space. So when the subarachnoid hemorrhage is confined to the subarachnoid space, they present with severe excruciating headache, but may not present with any neurological deficit. So one of the very interesting concepts of subarachnoid hemorrhage is that patients will present with severe excruciating thunderclap headache without any neurological deficit. Two questions have to be answered. Why is there headache, and why is there usually no neurological deficit? Patient presents with severe headache because subarachnoid space, there is hemorrhage in the subarachnoid space. That means subarachnoid area is affected. That means meninges is affected. Meninges is a highly pain sensitive structure and therefore results in pain and headache. Brain by and large is insensitive to pain. We cut brain, there is no pain, but meninges and vessels in the meninges are highly pain sensitive. That's why patients who present with ischemic stroke or hemorrhagic stroke confined only to the brain, they usually don't present with headache. Only subarachnoid hemorrhage they present with headache. We've seen a lot of ischemic stroke patients, they don't complain of headache, but subarachnoid hemorrhage they complain of headache because the meninges are affected. Meninges is a highly pain sensitive structure. So the three important diseases which affect meninges and cause severe headache is, one is subarachnoid hemorrhage, because the blood is seen, the chemical irritants are seen in the meninges, affecting the meninges and producing severe headache. The second is meningitis, because there's an inflammation of the meninges because of the infection. Meninges is involved, meningitis patient present with severe headache. And third, migraine, the trigeminal-vascular system is affected, the meninges is affected, they also present with headache. So meninges is a highly pain sensitive structure, and therefore when the meninges get affected, they'll have severe headache. The second important concept is that they may not present with neurological deficit, because if the hemorrhage is confined only to the subarachnoid space and is not penetrating or entering the brain parenchyma, they may not present with deficits. So as long as hemorrhage is confined only to the subarachnoid area, they do not present with neurological deficit. So a person presenting with severe excruciating headache but without any focal neurological deficit, we should always suspect subarachnoid hemorrhage. But then if the hemorrhage enters the brain parenchyma or compresses the cranial nerves, it can present with neurological deficits. For example, one of the common sites of subarachnoid hemorrhage due to rupture of the aneurysm is the posterior communicating artery. So if the posterior communicating artery enlarges and then ruptures, there is a close proximity, there's a proximity with the third cranial nerve. So they can present with the manifestations of the third cranial nerve palsy. So one of the common causes of third cranial nerve palsy is always a posterior communicating artery aneurysm. Since it's an aneurysm, it goes and affects the periphery of the third nerve and then the third nerve. So the parasympathetic fibers are running superficially on the periphery of the third nerve. So they are the first to get affected. So there will be pupillary abnormality. Parasympathy causes constriction of the pupil. Since it gets affected, there will be pupillary dilatation. So compressive third nerve palsy is like subarachnoid hemorrhage due to posterior communicating artery aneurysms. The pupil is the first to get affected. There will be pupillary dilatation because parasympathetic fibers are superficially placed. But if it's an intrinsic third nerve palsy like diabetes, it affects the center of the third nerve. So the parasympathetic fibers which are superficially placed may escape, and therefore diabetic third nerve palsies are sometimes known as pupillary sparing third nerve palsy. So if the hemorrhage is confined to subarachnoid space only, there will be severe excruciating headache but no focal neurological deficit. But then if it enters the brain parenchyma and affects the cranial nerves or other structures, there will be neurological manifestations depending upon the site involved. For example, the posterior communicating artery is involved, there will be third nerve palsy. Approximately 90% of the aneurysms arise from the branches of the anterior half of the circle of Willis. So if we take circle of Willis, more than 90% of the aneurysms arise from branches in the anterior half of the circle. So if we see the imaging, we'll be able to understand it better. So here you can see the circle of Willis. These are the two vertebral arteries. They form the basilar arteries which divide into the posterior cerebral arteries, and here you can see the posterior communicating artery. See, here you can see a close relationship between the posterior communicating artery, that is, this is the posterior communicating artery on this side, and this is the posterior communicating artery this side, and here you see the close relationship between the third cranial nerve and posterior communicating artery. So if there is a dilatation of the posterior communicating artery resulting in aneurysm and rupture, it goes and impinges on the third nerve and they can present with the third nerve palsy. See, again you can see here, this is the posterior communicating artery, this is the middle cerebral artery, this is the anterior cerebral artery, and this is the anterior communicating artery. Again, if there can be aneurysms in the anterior communicating artery here, yeah, this is the ophthalmic artery. So here again the anterior communicating artery, or at the bifurcation, this is the middle cerebral artery which bifurcates into the superior division and the inferior division. So again there can be aneurysm at the bifurcation here. So you can see here the bifurcation can be at the middle cerebral artery. You can see you can see here at the anterior cerebral artery and the anterior communicating artery aneurysm, and here the posterior communicating artery here. So aneurysms in the anterior part of the circle of Willis, aneurysms in the anterior part of the circle of Willis are more common than the posterior circle of Willis. Here you can see this is the two posterior cerebral arteries forming the basilar artery dividing into the two postcerebral arteries, and aneurysm can occur in the basilar artery also. So by and large, aneurysms are seen in the anterior circulation rather than the posterior circulation. See the space, the area depicts the aneurysms. So diagram of the circle of Willis showing the principal sites of intracranial aneurysms. Approximately 90% of the aneurysms arise from the branches of the anterior half of the circle. The sizes of the aneurysms depicted corresponds roughly to the frequency of the occurrence of these sites. So it is very common in the anterior communicating artery, at the bifurcation of the middle cerebral artery, and at the posterior communicating artery. The size is lessened here at the top of the basilar artery. Here they may be present but less common as compared to the anterior circulation. So anterior circulation circle of Willis aneurysms are more common. About 90% are seen in the anterior circulation. But we'll be able to understand better with the neuro imaging. So here you can see this neuro imaging. So this is the classic findings of neuroimaging findings of subarachnoid hemorrhage. So you can see here, this is a rupture of the basilar artery. So you can see the axial CT scan at the level of the lateral ventricle showing widespread blood in the subarachnoid spaces. So you can see here in the Sylvian fishes, here you can see in the ventricles, lateral ventricles. In fact, the blood appears white, so you can see the hypertense blood mixed with the CSF. So this is the CSF black and this is the blood which is white in color. So showing widespread hypertensive blood in subarachnoid spacing and layering within the ventricles with resultant hydrocephalus. Because these blood products go and obstruct the pathways of the CSF, it can result in dilatation of the ventricles and hydrocephalus. So there's a blood CSF level in the posterior horns of the lateral ventricle, typical of recent bleeding. At the level of the basal cisterns, the blood can be seen here in the anterior fissures. You can see it in the sylvian fissure and the anterior interhemispheric fissure and in the temporal. So the temporal horns of the lateral ventricle are enlarged, reflecting the hydrocephalus. So this is the perimesencephalic cistern. The blood is gone into perimesencephalic blood. You can see in the sylvian fissure, you can see in the anterior hemispheric fissure, and here you can see the blood mixed with the CSF. So because of the obstruction of the CSF pathways due to blood, it has resulted in hydrocephalus, that is the enlargement of the ventricles. So these are the wonderful concepts of subarachnoid hemorrhage. I hope you have enjoyed listening to these wonderful concepts of subarachnoid hemorrhage. You have enjoyed it. Please like the channel. Importantly, I have written 2 books: Exam-Oriented Clinical Neurology, which contains all important concepts of clinical neurology. So this will be especially useful for students preparing for clinical neurology exams. The other important book I've written is Focus Neurology. This contains all the important theoretical points of neurology written in a question and answer format. This book is available online from all leading booksellers, including Amazon. So if interested, this book could be purchased online. This book is especially useful for students appearing for Viva or oral exams, and since this book is in a question and answer format, this book is easily understood and very interesting to read. I hope you have enjoyed listening to these wonderful concepts of subarachnoid hemorrhage. If you have enjoyed it, please like and share the link, but please subscribe to my YouTube channel, Dr. Sreenivas Medical Concept, which is one of the India's leading neurology educational YouTube channels, and also my FB page, Dr. Sreenivas Concepts. Thank you. Bye.